once again for joining me as we continue our discussions around the COVID-19 pandemic. The program is Your Doctor and COVID, and I'm Dr. Mahendra Carpen. I'm the Head of Medical Services and Cardiology at the Georgetown Public Hospital Corporation. We continue to take questions and comments from viewers and listeners just like yourself. And remember, if you have any questions or comments, please feel free to send us a WhatsApp message to 620-6275 or send an email to docandcovid@gmail.com. Today, we are in a different period in our management of COVID-19 in Guyana. The last week of November 2020, we have had a significant move in the physical location for the management of COVID-19 patients. The really sick patients and the very symptomatic patients at the beginning of this pandemic up to the end of November were admitted and managed for the most part at the Georgetown Public Hospital Corporation. So as we continue to manage these patients, infrastructure development happened, and we were able to move them now to the Liliendal Ocean View facility. For the rest of this conversation, I will take my mask off. As you know, I usually wear it covering my nose and mouth, which is the correct way, but I'll take it off so we can continue this conversation. So at the end of November, we would have had a significant shift, a significant change in where we manage patients with COVID-19 who are pretty much sick and severely ill, requiring hospital care. The majority of those patients would have been admitted to the Georgetown Public Hospital in either the COVID ICU or the transition or step-down area. And over the past several months, that is the option that we had. At the same time, development was happening in parallel at the Liliendal Ocean View facility to make it into a COVID hospital. And early December, we were able to have patients who would have otherwise been at the Georgetown Public Hospital now being managed at the Liliendal facility. So what has been our experience at the Georgetown Public Hospital? To date, or at the end of November, we would have had 253 admissions to the COVID ICU at the Georgetown Public Hospital. 241 of those persons were confirmed positive. That means 12 persons who were there were not positive. And we believe that those 12 persons were what we call false negatives. And that's a very well recognized phenomenon when you test for infectious diseases. Because these persons have all the signs, all the symptoms, all the clinical features of COVID-19, and we manage them as such, but their lab tests came back negative. So those fall under the category of what we call false negative. At the Georgetown Public Hospital, there was a total of 104 deaths. Of that 104 deaths, there were 63 in the COVID ICU, and 20 of those deaths actually occurred in the emergency room. And that's a very important number to recognize. That's almost 20%. Now, if you think back that persons come to the hospital, if they're sick, they go to the emergency room, they're stabilized there, and usually within a 24-hour period, they are then transferred into the most suitable area of the hospital for them. So 20% of patients actually got to hospital and died in the emergency room. One can assume that they died within 24 hours. What that tells us is that persons were quite sick before they actually got to hospital. and we didn't really have, or they didn't have a chance to get stabilized and moved to another part of the hospital for continuing care. And we need to understand and address why persons are reluctant to go to the hospital even though they are sick or they would have been sick at home. Part of this in the early stages may have to very well do with the stigma that is associated with COVID-19. Persons are very afraid of letting it be known that they are COVID-19 positive, or any member of their family is COVID-19 positive, because they have a feeling or a fear that they may be shunned or ostracized by the society. But as we got more and more into this pandemic, our comfort level and our acceptance of this phenomena is better. And so hopefully that fear of stigma and that fear of ostracization is no longer there, and persons can seek appropriate care in a timely manner. At the Liliendahl facility, and this is the first week of December in 2020, we would have had about 42 patients in total who are admitted to that facility. One pediatric patient, that's one child, 5 maternity patients, these are expectant mothers who are known to be positive. We have 4 persons in the COVID ICU. This is separate from the maternity, separate from the pediatric patient. And of those 4, 1 person is actually on a ventilator, and 2 persons are receiving respiratory support by way of CPAP. CPAP is continuous positive airway pressure. There is a mask that is fitted onto the face and essentially continuously forcing oxygen into that patient's lungs. It's a little bit uncomfortable, but in the fight against COVID-19 and sick patients, it is actually quite necessary to maintain good ventilation in these patients. If we look on a national scale what our numbers actually look like, it will help us to understand a little bit more about where we stand in the world and in our fight against COVID-19. As of the end of November, November 27th, we would have had 5,310 total positive persons in Guyana, with an unfortunate 149 deaths, which gives us a case fatality rate of 2.8%. Now, a case fatality rate essentially is a percentage of deaths versus the total number of positive. And our case fatality of 2.8 is within what the WHO had described as the worldwide case fatality rate, which is 2 to 3%. Bearing in mind that there are countries that are doing better and there are countries that are doing worse. Guyana is right pretty much in the middle on average. We are no better, no worse than persons around the world in general. In fact, the WHO has recognized that despite various differences in admission criteria and treatment protocol, death rates across continents remain the same, regardless of socioeconomic status in the countries that are affected. And so far, we have had 4,272 persons who have recovered from this condition. As of December 6th, our numbers jumped again, and we see this every week. We continue to test, so we will continue to find more positive cases. Fortunately, we seem to be having a slowdown in our deaths, and we welcome that very much. At the first week of December, we're at 153 deaths, and over 4,750 persons recovered. If we look at the chart or the graph of our deaths in Guyana, we would see that the early stages was quite flat, but we started to see a rapid rise to a peak from August, from the first to second week of August, and we seem to be plateauing at about 150 where we are now in early December. It is very difficult to predict where we will be in January or February, but some of the fear that we have because of the holiday season, because of traveling, because of relaxed behavior and failure to maintain appropriate protection like personal protection, wearing a face mask and social distancing, etc., that we may have a spike in January or February again. And that's something for us to all be vigilant about and do our parts to prevent. In terms of testing that is available in Guyana, there are 3 types of tests that we can discuss. The most reliable, the one that we all know about, is the PCR testing, or polymerase chain reaction testing. That is the one that looks for the genetic material of the virus. It is the most accurate, however, it has the longest processing time, and it needs, of course, more trained personnel and resources to do this. The rapid viral antigen test is also now recently made available in Guyana. I believe we would have sourced about 20,000 kits, and these are deployed across the country to be used by trained healthcare professionals to make early diagnosis of COVID-19 active infections. It is a rapid and inexpensive kit. However, there are some concerns about accuracy. And of course, the one that has been around for a little while is the rapid antibody serology testing. It is rapid, it can detect the disease spread. However, there's a lot of false positive and a false negative concern. So we use it more for epidemiologic purpose rather than diagnostic purpose, and that's the rapid antibody testing. Viral antigen tests, the ones that are available, we have a couple. They have this one that it looks specifically for the COVID-19 antigen. And these tests are just like pregnancy tests. There are 2 lines that you look for. One is the control line, and the other line is the test line. So if you have a test positive but nothing shows up on the control, you know that's an inaccurate test. It's to be repeated. You need to see the control showing some indication that it's activated before you could actually interpret the test line. So that's very important for us to understand. You cannot just have the test line showing positive and nothing showing on the control line. There's a reason why they put that in control. Some other kits that are available for rapid antigen also do what we call a double test. They test for the viral antigen to COVID-19 at the same time that they test for the flu infection. So they can have, instead of 2 lines, control and test, you could have 3 lines. One for the flu, one for COVID antigen, and the other one as the control line. And these are all very important developments as we continue to find and we continue to look for accurate ways and means of testing for the COVID-19. The other question that we have to address is who really needs the rapid COVID-19 antigen test. These tests can be performed on individuals who have exposure to a person diagnosed with COVID-19. Persons are also encouraged to get rapid antigen tests if they experience signs and symptoms consistent with COVID-19. And we have talked extensively about signs and symptoms in our previous episodes, but just as a reminder, these include fever and chills, fatigue, difficulty breathing, nasal congestion, cough, sore throat, headache, nausea, vomiting, body aches, and the one that we have recognized as a unique thing is loss of taste and smell. So remember, if you have questions concerning the COVID-19 pandemic, please feel free to send us WhatsApp messages to 620-6275 or send an email to docandcovid@gmail.com. Thank you once again for joining me as we continue our conversations.